All right, everybody can hear me?
Yes.
So I think Emily's seen most of this before because I'm basically going to give basically the same lecture I gave at our neurotrauma symposium here at Elmhurst back in September, but it's kind of an overview of kind of best practices in spine and spinal cord injury, and we can, get into a discussion about some of the nuances as we go forward. Some of this will be, a little bit of basic and review for you guys, but then some of it may be new for you as well. Let's see here, no disclosures. Um, I always like to start with a case. So this was a case that was here at Elmhurst, which was a 54-year-old male motorcycle crash victim, approximately 40 miles per hour. He had polytrauma. He came in with an Asia B spinal cord injury. So that would be motor complete but sensory incomplete spinal cord injury. L2 was the neurological level of injury. You can see in this um, on the CAT scan that he's got, a burst fracture of uh, both T11 and T12, complete burst fractures, an incomplete T11, sorry, and a complete T12 burst fracture, retropulsion of bone fragments into the canal. He had a right pedicle fracture. He had, on the MRI, he had some posterior ligamentous uh, complex disruption, uh, and his neurological level of injury was L2. Was motor complete, as I mentioned, with no motor preservation, 3 levels below the level of the injury. No voluntary motor contraction on the rectal exam. So you would need both of those to be considered a motor complete. And sensory incomplete, meaning he had some preserved sensation in the S5 or S4, S5 dermatomes, or the other way you could be sensory incomplete would be to have deep anal sensation during the rectal exam. His other injuries were that he had a open left distal tib fib fracture and a pubic ramus fracture. He went to the OR for emergent OR for given the fact that he had a uh, significant spinal cord injury with active neural element compression. He had T11 to T12 laminectomies, decompression of the thoracic spinal cord. Corpectomy cage was placed because the likelihood that complete burst fracture would eventually result in a kyphotic deformity and pain and either cause failure of his posterior instrumentation or need future surgery was pretty high. So we placed a corpectomy cage for anterior column support, and he got T9 to L2 posterior instrumented fusion. So the time from the injury, if you see his EMIS was called like a little after 2. He was out of the OR, and it took a long. The case was long, so he got out of the OR at like 7 o'clock in the morning. But the time from the injury to the OR was about 5 hours actually. So he was in the OR about 5 hours. Another hour to make incision. He was decompressed relatively rapidly, so I think it was like probably 2 more hours to decompression. So probably about a total of about 8 hours to actual decompression. Um, we then augmented his mean arterial pressure greater than 85 for 7 days afterwards. He had 7 days in the SICU, and then his hospital length of stay was 34 days, which is often here a factor of the ability to get them into rehab as necessary. And he was eventually discharged to acute subacute rehab after he had his ORIF of his left tib fib fracture. Those are just some pictures postoperatively. So, in terms of spinal cord injury, there's, about a quarter to half a million spinal cord injuries per year worldwide. So it's about 40 to 80 cases per million population. There's about 17,000 spinal cord injuries per year in the United States, and this is data from the kind of like the early 90s to about 10 years ago. Um, the prevalence, there's about a quarter million to almost half a million people in the United States living with the sequela of a spinal cord injury at any one time. It's more common in young adults and now the elderly in particular, as people are getting older. We're having a larger and larger population of elderly patients, and their bones, obviously, with osteoporosis and the ankylosed spines, are predisposed to significant injury. So uh, typically, males are more often than females, and then non-Hispanic blacks make up about 23% as well. Cervical is more common than thoracolumbar, but pretty close, pretty evenly distributed. Uh, the etiology really depends upon where you are. So, um, most common in the United States until recently, and still the most common worldwide, is a motor vehicle accident. Now in the United States and in a lot of kind of like higher income countries, Canada, Europe, it's really falls, and that's increasing, and that's again particularly in the elderly population, it's increasing. Um, Also in New York City, we have less cars, we have taller buildings, so we have a lot of falls from buildings, a lot of fall from construction, um, and we have the other thing in New York City that is higher than a lot of other places is pedestrians hit by a car. Um, yeah, violence, assault, gunshots, they're relatively rare causes of spinal cord injury. Um, Now, when less than 1% of spinal cord injury patients experience a complete neurological recovery by hospital discharge. I mean, I think that we would all agree that's really the case. It's very rare that somebody with any degree of spinal cord injury has recovery, 100% complete recovery by the time they leave the hospital. Um, in terms of lifetime costs and life expectancy, so you can see that the treatment and lifetime cost of medical treatment of somebody that has a spinal cord injury is not insignificant. It makes intuitive sense that the higher the level of injury, the more functionally impaired they're going to be. So that is going to increase the lifetime cost. So high tetraplegia, is more expensive than low tetraplegia. If it happens when the patient's younger, they're obviously going to incur most costs. So, if it's high tetraplegia and say somebody that's 25 years old, it's about $5 million over their lifetime. If they are less functionally injured, so say they're ASIA D, which is motor function at any level. Well, that's not necessarily a D, but this would be anti-gravity basically in all motor, and in at least 50% of them. Motor levels below the level of injury, you can see it's dramatically less, and it's obviously less if you're older too. But also in terms of life expectancy, as you can see, there is if you have no spinal cord injury at 20, you're expected to live until you're about 80. But if you have, say, like a high tetraplegia, your life expectancy is only about half of what it would otherwise be. So there is, you know, significant reduction in life expectancy for somebody that has a severe spinal cord injury, and obviously the higher the level of injury, the more reduction there is, and that's a lot to do with you know wound, skin breakdown, getting infections in particular. So here at Elmhurst Hospital, we participated in the global neurotrauma outcome study, spine. We participated in the cranial one a few years ago. We just finished participating in the spine one over the summer. And during our enrollment period, which was it's only like 30 days, basically several hundred hospitals around the world participated, but only really a few in the United States. But we were one of them. We would basically collect all the data of all the spine trauma patients that were admitted to the hospital within a 30-day period. So we had 14 during that 30-day period, 4 that were spinal cord injuries, 5 that were operative cases. We had about 150 to 200 spine trauma admissions per year, including, everything from TP fractures to more significant injuries. About 25 to 50 are spinal cord injuries, and we have about 40 to 50 operative spine trauma cases per year, really. So any sort of neurotrauma care, what we do in the hospital is only one small bit. It really is a chain of care, and each link in this chain is vitally important. That's the pre-hospital care. If patient's not oxygenated, or their blood pressure, they're left to be hypotensive, or in the case of a spinal cord injury with an unstable spine, they're moved without immobilizing the spine. They might have additional injuries. Then, really nothing else matters after that. They kind of have been, irreversibly injured at that point. So EMS pre-hospital care is vitally important. The ED trauma center initial response is vitally important. Surgery, if necessary, the post-operative critical care, the post-injury critical care, and then rehab as well, because we know that if you take the same group of people and one group gets rehab and one group doesn't, the ones that get rehab are going to do much better than the ones that don't. So in terms of spine and spinal cord injury, there are several major kind of guidelines that you guys should be aware of, and our current hospital protocol incorporates aspects of all these. We've used all of them in our protocol. So the first is the double ANS CNS guidelines for the management of acute cervical spine and spinal cord injuries. That was in 2013. It really is specifically cervical spinal cord. However, we do extrapolate from that to, or we were extrapolating from that to thoracolumbar a lot. But then in 2018, they came out with the guidelines for the evaluation and treatment of patients with thoracolumbar spine trauma. So both of these are we use, and then we also, our protocol, we incorporated a lot of stuff from the AO Spine guidelines, which are an international clinical practice guidelines. And this was for the management of degenerative cervical myelopathy, obviously not spinal cord injury, but then also spinal cord injury. So there is some stuff there's a lot of stuff that's in agreement between the two, but there's some stuff that's a little bit different between the two. So you can find our spine trauma and acute spinal cord injury protocol. It's on the SharePoint. So if you go to the intranet pages on Elmhurst and you find at the bottom there's a bunch of links. One of those is a SharePoint policies link. There you can access the policies of and protocols of any department in the hospital. You can search it by name, or you can just go to the department. So our trauma ones for head trauma and spine trauma are in our neurosurgery one, and they're also, I believe, linked from the trauma website. So there's another separate website that is on the top that you would go to where it says clinical protocols, and I can show you after we're done here. But clinical protocols, and you can go to the trauma one, and it should link to ours. But basically, it's very long, and part of the reason it was very long is we really wanted to incorporate all these things into it, all the way from ED in terms of initial management, as well as diagnosis, critical care management, prevention of secondary insults, the optimization of spinal cord perfusion, and then guidelines for definitive decompression and stabilization. So all of those are addressed in our protocol. I'm going to be updating it this year, probably to incorporate more about lumbar drainage and spinal cord perfusion pressure monitoring, which we'll go into. So, some of the key points, anybody that has a potential spinal cord or spine injury, first you need to have a suspicion for the injury, and that should cause prompt transport by EMS to a trauma center. You want to do spine immobilizations to prevent secondary injury, particularly when the trauma may have resulted in an unstable spine. You don't want to have those pieces moving basically and causing additional injury to the spinal cord or the nerve roots or the conus medullaris. They've gotten away from using backboards in New York City, and that's because there's a fair amount of evidence that when they brought patients in on backboards, the patients would stay on a backboard for hours on end, and then they would get pressure ulcers. And one could say, well, why not just make sure you remove the backboard quickly? And even with trying to do that, basically, if a patient was left on it even for like 20, 30 minutes, they were more predisposed to getting pressure ulcers. And there's not a lot of evidence that using a backboard is significantly better than using a sheet and just being careful when you move somebody. I think for cervical collars, there's a lot more evidence that cervical collars are probably helpful, and I think we are, I think neurosurgeons in general we're okay with giving up the backboard, but we would not be okay with giving up, I think, the cervical collar, particularly since, cervical collars don't cause nearly as much of an issue, and we're pretty good about removing them reasonably quickly if somebody doesn't have an injury. You want to prevent hypotension and hypoxia. These are kind of like the two biggest things besides, repeat compression really, or worsening compression that are going to cause additional injury. So those are like two of the most important things, preventing and treating any hypotension and hypoxia. in terms of a neuro exam, really what we're looking for is to see, does the patient have any neurological deficits? Number one, is that deficit likely to be related from nerve root compression? In other words, if it's one, myotome, or they have a sensory deficit that's just in a dermatome or a couple dermatomes, then it's probably likely nerve root compression. If they have, multiple myotomes involved, or it's not in the distribution of, one or two nerve roots, then it's probably a spinal cord injury, and then the assessment is whether it's going to be an incomplete or a complete spinal cord injury. Getting prompt imaging, obviously CT is the go-to. If anybody does have either a cervical or a thoracic, particularly high thoracic, but really any thoracic any cervical or thoracic spinal cord injury should really get a CTA of the neck if it's cervical, and if it's thoracic, you should also look at both the neck and the chest really to make sure the aorta isn't injured. And I wouldn't fault anybody for doing that even in a lumbar fracture too, to make sure that the iliac arteries are okay. MRI potentially, not always necessary, and then occasionally X-rays, particularly if you're trying to determine whether or not somebody's fracture is stable or not. Early surgical intervention if it's indicated, so decompressions and spinal cord stabilization, and then postoperative management, including MAP augmentation, especially if the patient has a cervical or a mid-thoracic spinal cord injury because they are at risk for neurogenic shock, and then ventilator management. So somebody that has a spinal cord injury, particularly cervical, the cervical spine, their phrenic nerve may not be working. Their intercostals may be weak, and they often need higher tidal volume. So whereas typically in the ICU we're doing like 6 to 8 milliliters per kilogram, really in somebody with a high cervical SCI, you really want to be doing around 10 to 12 cc's or milliliters per kilogram tidal volume. So you want higher tidal volumes, lower vent rate. And then bowel and bladder management are very important to prevent ileus and make sure you're not having urinary retention, which are often, very common after a spinal cord injury. And then post spinal cord injury rehabilitation. So this is what the international standards for the neurological classification of spinal cord injury, or the INSCI exam. This is when we talk about ASIA scores, we're really talking about one part of what's called the INSCI exam. So the INSCI is like the really formal way of doing a neurological exam and documenting it, and anybody with a spinal cord injury. So when we're doing research on spinal cord injury patients, we have to do it precisely this way, and each testing level, so like you touch light touch and pinprick and in specific dermatomes, and you don't pick random spots in those dermatomes. There's actual specific spots you have to pick, which are indicated by these little dots you see here. So, for instance, myself and Dr. Capinos, like we were, the previous spinal cord injury trial we had going here and the new one coming out, we get certified in this, so which involves initially about 6 to 8 hours of online training, and then a day basically of them going through cases with you and also having you do it on people, and then we have to get recertified, like I think every 2 years. So I've had to do this several times. Karam's graciously been my guinea pig multiple times. So basically, you have to do that light touch and pinpricking. There's a specific way you have to do it. There's a specific way you score that. And then when you do the motor exam are these ones in these separate boxes on the right here and on the left. So there's 10 on each side, 10 in the upper limbs. So 5 on the upper limbs on the right side, 5 on the upper limbs on the left side, 5 on the lower limbs on the right side, and then 5 on the lower limbs on the left side. Those are your motor testing muscles. And they differ a little bit than what we do clinically. Like, so for C5, it's elbow flexors, it's not deltoids, and that's because the deltoids can give you, if somebody's uses their trapezius, it could give you a falsely reassuring result. So there's elbow flexors, and there's specific ways you're supposed to test these. So like specific orientation of the limb, and we start off with actually grade 3 first and see if they can do it anti-gravity. And then if they can do it anti-gravity, then we test to see if it's a 4 or 5. There's no 4 plus, there's no 4 minus. Those are things we use clinically, but those actually aren't part of the score. But basically what happens is you end up scoring up all those things. And then you determine the sensory level. So the sensory level is the basically you go down until one of these is abnormal. That's your sensory level. So if say C2 and C3 and C4 are both normal to light touch and pinprick, and then C5 was abnormal on light touch only, say, then C4 is your level of injury. It's um, so it's like the first one that is it's the most it's basically it's above the first level of the first abnormality basically. And it can get a little tricky because sometimes light touch or pinprick, pinprick in particular, because it's abnormal even if you can feel it, but you can't tell the difference between light and touch, sharp and dull, that counts as abnormality. So anyway, without getting into the weeds too much, you figure out the sensory level on both sides, and then you figure out the motor level on both sides. And the motor level is not like the first one that is um, necessarily abnormal. It's the first one that's not anti-gravity, I believe, if I remember correctly. Um, and then assuming that the ones above it are normal. So can get a little bit complicated. There's a lot of different rules about things, but basically the neurological level of injury is once you have all of these ones, the neurological level of injury, I believe, is, so I'll show you. There's like a whole. This is like how you actually grade things. Um, so I believe the neurological level of injury is supposed to be in here somewhere. Yeah, it's the most caudal, yeah, segment of the spinal cord with intact sensation and anti-gravity, 3 or more muscle function strength, provided there's no more normal muscle function rostrally. So if you had basically, and it's the most cephalad of the sensory and motor levels determined in 1 or 2. So if you basically had, if this was say C6 and this was C6 and this was C5 and this was say C6, C5 would be your neurological level of injury. So then in terms of doing incomplete or complete, this is where the rectal exam becomes extremely important, because the rectal exam is what tells you whether or not it's a complete injury or an incomplete injury. If you had no motor movement, say below L2, so say you could flex your hips, you had a 3 in your hips, and everything else above you was normal, and then you had a 2 here, and then the rest were zeros, your neurological level of injury, at least up until this point, is going to be L2, um, because that's the lowest level with at least a 3 or more, and everything else above it is normal. But just because these are zeros below them doesn't mean it's a complete injury yet. You have to figure out what is happening in the S4 and S5 dermatomes, and the only way to do that is with your rectal exam. So basically what you want to do is technically you want to do light touch and pinprick. Obviously clinically we don't typically do that. We just do light touch in the S4 and S5. So S3 is actually over the ischial tuberosities. You can see it here on the left side. That's where S3 is. S4 and S4, S5 is right where basically the anal mucosa reaches the skin. So right at that juncture, you want to test that on both sides, whether they have light touch or pinprick. If they don't have any sensation there, then you want to do your rectal exam, and what you want to tell the patient is that you're going to, insert your finger about 1 inch into their rectum, and then you're going to press. The first thing you're going to do is press against the inside of the wall of the rectum, and you want them to tell you if they can feel it when you push on the inside. So you insert your finger, you push, and then you see if they say that they could feel it or not. And you could do it, again, if there's any concern, and that whether they can feel it. And so that's the deep anal pressure. And if they feel that, that means they still have sensation in the rectum. And so that patient would not have a complete spinal cord injury. It could be only, the worst they could be would be an Asia B. They could still be a complete motor, but could not be a complete injury. The second thing you want to ask them to do is then to squeeze around your finger and then see if you can feel them squeeze, actively squeeze, and then you want to ask them to relax and see if you can feel them actually relax. So you don't ask them to bear down because that will actually relax the sphincter, which is not what you want to do. You want to see if they can voluntarily contract their anal sphincter, and that it will determine whether or not they have a complete motor injury or not. So if they can contract that, then by definition, they can't have a complete motor. They can only be an incomplete motor. So the worst they could be would be an ASIA C. So you can see how this really determines if all these are zeros. So if they have no voluntary anal contraction, no deep anal pressure, and no sensation, they're a complete spinal cord injury. If they have no voluntary motor anal contraction, zero here, zero here, zero here, zero here, but they can feel it when you push on the inside of the rectum, then there would be an ASIA B. If they had no voluntary motor contraction, no deep anal pressure, but they could feel it when you touch, in the S4, S5 dermatome. Again, they could only be an ASIA B at worst. And if they have any voluntary motor anal contraction, then at worst they could be an ASIA C. So it's very important. And you'll notice that like tone, right, was not one of the things that I mentioned. It's not on here anywhere. And some people, you can record it up here in comments, like as a non-key muscle or something, but it's not, tone is actually not one of the things that determines whether the ASIA grade of a patient. So we just kind of went through all of this. Secondary components, though, so presence of an anal wink. So this is a perineal reflex mediated by S2 to S4. This is when you have reflexive contraction of the external anal sphincter upon stroking the skin around the anus. So where you would probably see this is when you test S4, S5 for light touch and pinprick. If you see that the external anal sphincter contracts, again, that can be a reflex contraction. If you don't see it, the absence indicates that you may have disruption of the reflex arcs in the lower sacral levels, but you can't really say for certain that the absence means that. I mean, it's only, but it could. And then the bulbal cavernosus reflex. It's a polysynaptic reflex, again, S2 to S4. It's useful to test for spinal shock. So spinal shock is the loss of it's the loss of reflexes, spinal-mediated reflex immediately after an injury, spinal cord injury. So either squeezing the glands of the penis or the clitoris, or gently tugging on the Foley catheter can cause contraction of the internal, external anal sphincters. Absence indicates disruption or spinal shock. It's one of the earliest reflexes to return after spinal shock. So if you have return of this reflex without any motor or sensory function, that may indicate that the patient's got a complete spinal cord injury. Again, I don't usually bother with anything of these because obviously these can be a little bit sensitive to patients to be doing, and the information they provide I don't think is really all that useful, quite honestly. Usually, by the time the spinal shock is returned, you're probably going to know whether or not that patient has a complete SCI or not. So we went through kind of this briefly, but this is how you grade everything. In terms of the ASIA impairment scale, as we mentioned, E, so it goes kind of reverse. So E is normal. You can only have an E, though, if you did have a deficit and now the deficit's gone. So this would be somebody that, say, came in, they had transient weakness after a trauma, say in their left arm, and now it's normal. Again, that would be a patient that would be given an E for a spinal cord injury, assuming that you got imaging that confirmed it, or you highly suspected they had a spinal cord injury. D is motor incomplete, so this is where basically they have at least half or more of the key muscles, which are those 10 muscles on either side, at least half or more, or at least anti-gravity, so 3, 4, or 5 muscle strength, at least half below the level of the injury. So if you had a level of injury of, say, C8, then in the legs, at least half of the muscles in the legs that you tested, half of those 10, so 5. 5 or more would have to be at least anti-gravity or more, and it can be any combination. Motor incomplete, C. A C motor incomplete is basically the inverse of this is when motor function is still preserved in the most caudal sacral segment. So that means in both of these, you have to have voluntary anal contraction. If you don't, then you're motor complete. So, um, but and the patient, instead of having more, or at least half of the muscles anti-gravity below, then more than half of the muscles are not anti-gravity. So, or the other way of saying is less than half of the key muscles below the neurological level of injury have a muscle grade of 3 or more, so are anti-gravity. Then sensory incomplete is when you're motor complete. So you have basically there's no motor, it's no motor function preserved more than 3 levels below the motor level. So if your motor level was L2, you could have some motor function in L3 and L4, but L5 and lower, you would not have any. So if you have no motor function preserved more than 3 levels below the motor level on either side, um, and you have no voluntary motor contraction, voluntary anal contraction, anal sphincter contraction, um, but you do have some sensation or deep anal pressure, then you'd be sensory incomplete and you're a B. And then complete is no sensory or motor function in the sacral segments, S4, S5. So that's, I think, important for people to understand, because I think, if you don't know really how the rectal exam, um, fits in with everything, then, it's very easy to then miscategorize somebody as uh, motor incomplete when they're actually complete, or vice versa. So as I mentioned, another thing, spinal shock versus neurogenic shock. So spinal shock is the loss of spinal cord function and the loss of spinal cord mediated reflexes causal to the injury, with flaccid paralysis, loss of sensation, absent bowel and bladder control, and as I mentioned, loss of reflexes. So this is, often what you see after a very severe spinal cord injury for, a period of time. It can be a few hours, it can be a day or so. Neurogenic shock, however, is the loss of sympathetic tone with preserved parasympathetic function, which is secondary to the disruption of the descending sympathetic tracts within the cervical and upper thoracic spinal cord region. So you're going to really see neurogenic shock most likely if you're at T6 or above spinal cord injury. This results in hypotension, which is why it's called shock, bradycardia, and temperature dysregulation. So this is how you can determine clinically. One of the ways you can determine clinically um, from hypovolemic shock, or hemorrhagic shock. So somebody had hypovolemic or hemorrhagic shock, right? They would have hypotension. They should have tachycardia. But if somebody comes in with the suspected spinal cord injury and they've got hypotension and they're not tachycardic, so that would be considered like a relative bradycardia. So if they're have a normal heart rate, that would be abnormal if they were hypotensive. Sometimes you'll actually see that they're actually floridly bradycardic, which is even worse. Then that would clue you in that they have neurogenic shock as opposed to hypovolemic shock. They could have both, though, obviously, too. Spine imaging. We don't need to go through this too much because I think most of us know it. But I would say that well, yeah, I think we kind of went all over that. So in terms of classification, there's many different ways to classify spinal cord and spine trauma injuries. There's been many different iterations, improvements from previous classification types. One of the ones that we often learn is Denis, and the Denis classification of spinal trauma really categorize things into major injuries, compression, burst, seatbelt type injuries, fracture dislocations, and then minor injuries. And then it also there was initially a 2-column model, then he also had a 3-column model, which was anterior, which is the ventral one half of the vertebral body, middle, which is the pedicle, like the half of basically the one half of the pedicles, and the posterior one half of the vertebral body, and then posterior, which is the spinous processes, the interspinous ligaments, the lamina, the transverse processes, the facets, and half of the pedicles. And kind of classically, the classic teaching, is that if you had more than one of these injured, if you had 2 or 3 columns injured, then that was likely to be an unstable injury. And that holds true for a lot of cases, but not every case. So a more kind of recent classification is the AO spine classification. So I typically use this in any significant spine trauma, well, pretty much every spine trauma. You'll see in my notes, I classify it based upon the AO spine classification, and this has been validated both in several large studies, both kind of inter and intra-observer reliability is pretty good. It takes a little getting used to, but basically the main things to realize is that uh, so they have one for thoracolumbar, they have one for subaxial cervical spine, they have sacropelvic one. The sacropelvic one's obviously a little bit different. They have upper cervical as well, which is a little bit different. But the subaxial and the thoracolumbar ones are relatively similar, but they all follow the same principle, which is that you first have that the severity of the injury increases as you increase the letter and as you increase the number, but particularly the letter first and then the number next. So, for instance, type C injuries, which are translation injuries, are going to be usually significantly worse than type B ones, which are distraction, which are going to be worse than type A, which are compression injuries. Um, Typically, most of the ones in type A are going to be stable for the most part, whereas ones in B and C are going to be more likely to be unstable. C almost always unstable. And then the number also increases in severity. So within the compressive injuries, you have A0, which are basically minor non-structural fractures. So TP fracture, isolated spinous process fracture, laminar fracture. Then you have wedge compression fractures, which is basically one end plate fractured with with or without a little bit of kyphosis, but nothing else. So that's we see that very frequently. A2 is a split type fracture through the vertebral body, and this is the reason why this is different than this is because the split type ones tend to heal less well and they have a little bit more instability. A3 is an incomplete burst fracture. So what distinguishes a burst fracture from a compression fracture is whether the posterior wall of the vertebral body is involved. So if the fracture extends all the way back to the posterior wall of the vertebral body, then it's a burst fracture. So what distinguishes between an incomplete and a complete burst fracture is how many end plates are involved. So an incomplete one, it's only one end plate, either the top or the bottom, and it goes all the way to the posterior wall. Complete burst fracture, as you can see here, it involves both end plates and it goes back to the posterior wall. And you can have a laminar fracture associated with it, or you may not, and you can have retropulsion of bone fragments or not. And then I won't get into these, but you have these are more severe injuries: transosseous tension band disruption, other types of posterior tension band disruptions, hyperextension, and translation's obviously the worst. And the way there's kind of like a little algorithm for how to classify it, but basically what you do is you take the most severe level of injury, which is going to be if you have a C injury, that's going to be that level, and you write that level with the C, and then in parentheses you write everything else. So if they have multiple other levels that are injured, but they're not as severely injured, you would include which the levels those are and which type of injuries they had, and then at the end you give the neurological modifier, which is whether or not they're intact or whether or not they have a spinal cord injury. And then there's modifiers for if they have like an ankylosing spine or they have a lot of other comorbidities. So it's basically a way of, so somebody tells me, it's a T8, T9C. Okay, so that patient has a translation injury. It's T8, T9. They probably have a spinal cord injury related to that. At T9, they have an A3 injury, so they have an incomplete burst. At T9, obviously that's like the level below the translation, so that's all part of the same injury. N3 would be, I think, incomplete spinal cord injury, and then M2, I forget what the modifier is, but I think that I forget which one that is, but I have to look it up. But it can give you a sense of what the morphology of the injury is and whether or not it might be stable or unstable. Then I also like to use both the SLIC and the TLIX because this is, they do different things. The first one was the AO spine is really more of a morphology and description. It does tell you a little bit about the severity of the injury, but SLICS really helps with kind of translating into whether something might be non-surgical or surgical. Both of them use this 10-point scale where 1 to 3 would be typically non-surgical. 4 is kind of like dealer's choice, depends upon the surgeon or the comorbidities the patient has or other factors. And then 5 to 10 is typically something you would need to address surgically. Again, it's not always the case, but this does provide some guidance. And um, in each case, SLIX is for subaxial cervical spine, TLIX is for thoracolumbar. There's three categories. One is the morphology again. Two is whether the integrity of the disco-ligamentous complex or the posterior ligamentous complex. And then three, and you'll see, right, like the difference between these two is that the disc is kind of more important, really, particularly in the cervical injury. Um, uh, and that's partly because there's just, the posterior ligaments in the cervical spine and the facets from the lateral masses aren't quite as robust as they are here. Uh, and then the neurological status. And so, if you have something like, a burst fracture where they're intact and, you know, you're not sure whether or not, the facets look okay, the MRI is not too bad in terms of the ligamentous injury, you're not really sure, that's a patient that the number would be a 3, so, you would be justified in managing that non-surgically potentially. Whereas if somebody had, a distraction injury or say translation injury 4, like immediately, even without anything else, they would potentially be surgical. But then 4, if they have translation, they probably already have disruption of the discoligamentous complex, or 6, and then say they have a incomplete spinal cord injury, then they're going to be at a 9. So that's definitely something that would be surgical. Um, so our decision to operate really is, I kind of view it mainly on these three categories, and then, you know, balance that against the patient's medical stability and their ability to be able to withstand the surgery. So the first is neurological compromise or neural element compression. So, if they have active spinal cord compression that's causing an incomplete or a complete injury, or they have cauda equina compression or conus medullaris compression or nerve root compression. Those are things that are going to potentially cause me to operate. Spinal instability is next. So you have like the 2 or the 3 column models. Again, those are good to use here and there, but it does get a little bit more nuanced than that. You can have times when the disc may be disrupted, but the posterior, the facets are fine and the ligaments in the back are fine. And, typically that would still be a 2 column injury if the entire disc was disrupted, and they may still be okay with like external immobilization. But you do want to take into account the spinal instability. And if somebody has an unstable spine, then they may need surgery or they may need external immobilization of some form until the injury heals. But ligaments take a long time to heal, obviously, and bone takes about at least a minimum of 3 months, if not 6 months. And then the third is deformity or pain. So if somebody is likely to have a deformity that results from their injury, so a good example would be, that patient here at the very, very beginning. Even if this guy did not have a neurological level of injury, he's likely to have develop a kyphosis from this. Say there's a burst fracture, say that he has a fracture here, but say his facets were all fine. You could manage him non-operatively. You wouldn't be, it wouldn't be wrong necessarily, but there'd be a pretty high likelihood that he's going to develop a kyphosis that's going to cause either neurological compromise later on or persistent pain that's going to need to be addressed. And so, you can be justified in, operating and doing a corpectomy to prevent that in the future, given that likelihood. So, both in the acute setting and in kind of the chronic setting, deformity and pain are is an indication for surgery. That's usually related to, if it's in later, it's usually related to chronic instability, which then results in poor sagittal and coronal balance and chronic pain. Osteoporotic compression fractures can also be painful, obviously, above and beyond the kind of like the malalignment or the deformity aspect of it. And then you can also have other causes of pain, but other causes of pain such as musculoskeletal, myofascial, or discogenic actually respond pretty poorly to surgical intervention. So it's really kind of alignment and stability that respond good to surgical stabilization. So in terms of timing of surgery, this is really influenced by several other factors as well. The first is whether or not they have neurological impairment or not. If if they do, if they have an acute neurological deficit, then you know, generally speaking, you're going to want to operate. You're going to want to operate as early as possible once it becomes safe for the patient to have surgery. Um, Concomitant traumatic injuries, so if they have a severe traumatic brain injury with cerebral edema and swelling and ICP issues, that may be somebody, even if they have a bad spinal cord injury and active compression, that you're not going to necessarily take to the OR right away because, they could have a fatal secondary injury to their brain, or if they have bad thoracoabdominal injuries, pelvic injuries, uh, they have significant patient comorbidities or on full anticoagulation, antiplatelets, and the availability of your necessary resources, MR if you need it, OR staff, neuromonitoring, etc. Um, so there's, in terms of what the timing and kind of in general for somebody that comes in a spinal cord injury. So the old way of thinking about it was that if somebody came in and they had a complete spinal cord injury, was that those patients were kind of destined to not do very well. The prognosis of them improving from an ASIA A to an ASIA B even is about 8 to 10% of the patients, and so the thought was there wasn't much impetus to operate early on those patients, but that everybody else, so incomplete injuries, that you would operate as early as possible, basically, um, in order to try and preserve neurological function. That's the old way of thinking about it because nowadays we know that that 8 to 10% of complete spinal cord injuries, that if you operate within the first 24 hours, you can improve that number. That's also old data, and it's also extremely hard to tell if somebody has a complete spinal cord injury in the acute setting. Particularly, you think about it, a lot of these patients are coming in, they might have a TBI, they might have thoracoabdominal injuries, they're intubated potentially, they've just been given medications. It's very difficult to determine whether somebody has a complete spinal cord injury when they're in the ED versus an incomplete. And um, nowadays, the guidelines are to really basically treat complete and incomplete spinal cord injuries the same in terms of timing. Ideally, even central cord syndrome, which is kind of a little bit of its own special form of incomplete spinal cord injury, but to err on the side of operating on those patients early unless they have a very mild deficit that's improving rapidly. And that's mainly just because those patients tend to be older, they tend to have more comorbidities, and they tend to have less active ongoing compression. It tends to be more that they have a chronic compression and then have just kind of dinged their cord. So, you know, um, but early is really less than 24 hours, and late is more than 24 hours, at least by current definitions. This is changing kind of as we move forward. It's probably eventually going to be less than 12 hours. Ultra early is about less than 5, more like less than 8 hours. And more of us are trying to get patients in the OR and decompressed within this time window, within 8 to 12 hours, really. As you can see from that first case, it is pretty hard to get somebody into the OR and decompressed within much quicker than that. So the AO spine guidelines from 2017 recommend early decompressive surgery be offered as an option for adult acute spinal cord injury patients, regardless of the ASIA grade or their level. And so this was kind of the seminal paper, which was in Plus One, which is the STASCUS trial. Michael Failings from University of Toronto was the lead author on this. Alex Vaccaro is another big name in spine trauma who did like a lot of the AO spine classification stuff. James Harrop is from uh, John, Thomas Jefferson in Philly, and Chris Shaffrey, a lot of big names in here. But this was a multi-center international prospective cohort study, which looked at the safety and efficacy of early, less than 24 hours versus late, greater than 24 hours decompressive surgery after traumatic cervical SCI. So, I mean, keep in mind it was cervical, but if we do kind of extrapolate this to all spinal cord injuries, 313 patients, almost 20% in the surgery group had more than a 2-grade improvement in their ASIA score at 6 months, compared to only 9% in the late decompression group. So you were over 2.5 times more likely to improve if you got surgery early rather than late. Um, and then decompression prior to 24 hours could be safely performed. They really had, I guess this was my complication, right? They actually had less complications in the early surgery group versus the late surgery group. Um, so yeah, this is 10 years old now, but this is the standard of care now, and there are several other studies that have looked at even earlier time points and may end up changing that. There's a meta-analysis that we did here at Sinai with myself and Dr. Margettis, um, looking at ultra early, so less than 8 hours surgery for thoracic spinal cord injury, which is systematic review and meta-analysis. So, we had 5 studies that we included, and it seems to indicate that, there was a treatment effect, indicating that, ultra early seemed to have a potential benefit. I think the exact difference actually here was like, across the null, but you can see that they are a little bit spread out here. It's probably just not statistically significant based upon those, but if we get more studies that show similar results, then eventually that may change the timing. I think more and more people are aiming for less than 12 hours. And then we are also looking at a case series of our patients that were with spinal cord injury and those that got decompressed in less than 5 hours versus those that were more, which is, as we mentioned, extremely hard to do actually. So, one of the things, one of the reasons we might delay surgery is because we're worried about complications. And while there certainly are times when the patient is not medically ready for surgery, or particularly if they have other significant injuries that are still an issue and could become an issue during a long surgery, um, you know other complications are actually reduced by early surgery. There's a fair amount of evidence that operating early, when feasible, actually reduces complication rates, because obviously keeping somebody immobilized has results in infectious issues, particularly with pneumonia, may mean they need to stay intubated longer, may mean that they are more prone to pressure ulcers and things like that. Um, so this basically showed that, although surgery within 12 hours may not always be feasible, the data suggests that whenever possible, surgeons should strive to reduce the amount of time between hospital arrival and surgical intervention. Because patients in the early group had 1.5 fewer days in the critical care unit, and the odds of a major complication was significantly lower for those receiving surgery within 12 hours, about 23% lower. So if there's no neurological impairment, though, surgery is less urgent. If there's significant instability exists, the patient is still at risk of a secondary spinal cord injury, or even a primary spinal cord injury if they have instability and haven't suffered one yet. So you need to ensure strict spine precautions, external mobilization maybe, particularly if it's cervical with a hard cervical collar, and then you should really, plan for prompt surgery once they're medically optimized and resources allow. So that may be, if somebody comes in and they're neurologically intact but they're unstable, and they don't have active spinal cord compression, that might be somebody that you could operate, on the next day, rather than taking him in the middle of the night. So mean arterial pressure maintenance. So we'll move on to kind of post-operative care. So, in terms of hypotension, hypotension is extremely bad for patients with a brain injury, an acute brain injury, or an acute spinal cord injury. So you want to correct hypotension, meaning a systolic of less than 90, in patients with spinal cord injury as soon as possible. So all these, studies that have looked at like hypotension and hypoxia, they usually use 90 for both spinal cord injury and TBI. Although we know now for severe TBIs, we want to keep their systolics over 110, based upon the guidelines. And in terms of spinal cord injury, based upon the guidelines, we want to really maintain a map of over 85 to 90. They gave like a little bit of a range, but so we usually say just greater than 85. for 7 days after an acute spinal cord injury, whenever possible. And again, this is the caveat. So if, they're having troponin leak or they're having EKG changes and stuff like that, then it's better to not do this because, you're going to give them a heart attack. But as long as they're able to tolerate it, then that should be kind of the goal. Um, and so, people have looked to see, does it really matter, because the evidence wasn't super strong for us to start doing that, but it has become the standard of care. It's in the guidelines. And so people have looked at as to whether or not, it seems to be affecting outcomes. And in this study, they looked at 136 SCI patients. They looked at the 75 of them had augmented MAP, and basically the proportion of MAP measurements greater than 85 millimeters of mercury was determined to be an independent predictor of neurological improvement. So increased vigilance regarding MAP maintenance is warranted to optimize neurological recovery. So they did find that in the multivariate model that there was a significant association between the proportion of patients that had elevated MAPs and those that had neurological improvement. So it does seem to be helpful. In terms of steroid use, so steroid use is extremely controversial. There's, the history behind this is kind of very convoluted and long, but basically, essentially what happened was, when the first studies looking at steroids and spinal cord injuries came out in the mid 80s, this was based upon data that was done in like the late 70s, early 80s. That multi-center, 330 patients, they looked at moderate dose versus low dose methylprednisolone, and they found no difference between the two. But there was, in a post hoc analysis, there was a trend towards a better outcome for moderate dose methylprednisolone within 8 hours. So then this caused them to do another trial with more patients, roughly the same number of centers, and they were looking at methylprednisolone given as a bolus, 30 milligrams per kilogram, and then an infusion for 23 hours versus placebo. And they looked at early versus late, which was and this was also a post-hoc analysis. So they initially did this, and they really didn't see any difference overall, which is why they did a post-hoc analysis. They looked at the early versus the late, and they saw a small but statistically significant improvement in the motor and sensory function of patients that received it within 8 hours. So it was statistically significant, but the effect was so small as to be dubious whether it was clinically relevant, quite frankly, or not. And then there was a NASCAS 3 that, based upon this, looked at whether or not patients should get 24 hours versus 48 hours or a different drug. So, one of the flaws of all of these is that they're, multiple arms instead of just kind of like 2 arms in a lot of them, although this one had 2 arms. But, 3 arms in a trial is usually not a good idea, things like that. Basically, what this found was that there was no benefit to continuing past 24 hours to 48 hours, and probably actually worsened outcomes because they had increased complications from mainly infectious complications. This is, by the way, really high dosing of steroids. Like if you compared it against dexamethasone, it's quite a lot. And no benefit to ultra early administration. So based upon kind of these 3 studies, it basically became standard of care to give patients steroids if they presented with a spinal cord injury within 8 hours of their injury, was to give them this steroid regimen. And, became kind of entrenched. And then, interestingly, kind of starting in the early 2000s, there was really a push to reevaluate that, mainly because of the fact that it was really based upon this small clinical change that was statistically significant, but again, like, was it really clinically relevant? And again, it was a post hoc data analysis, and so basically, based upon the exact same data, and there was no major new trial, it was the exact same data, the AANS and CNS guidelines in 2013, which I mentioned before, basically kind of made a 180 on the recommendations, and they basically said that that there is really no class 1 or class 2 medical evidence supporting the clinical benefit of methylprednisolone in the treatment of acute SCI, and it was not recommended to use it. And some people, the reason why I mentioned that it's based upon the same data, and there's no new major trials, is some folks felt that was a little bit of an overcorrection, and that while there was the data was not great to support making it a standard of care and that everybody need to do it. Similarly, the data was not great that it should just be not given or that it was contraindicated, which is what the 2013 guidelines make it sound like. So then in the AO Spine 2017 guidelines, which are these international guidelines, it reintroduced methylprednisolone administration for 24 hours as a treatment option. So kind of in the middle ground, treatment option for adult SCI patients within 8 hours of injury. And this was based upon a systematic review and meta-analysis um, uh, of studies that had looked at this. It added 2 additional randomized controlled trials that specifically examined this time point compared to a post hoc analysis, and it added 1 prospective trial. Um, and so basically, they're found that when methylprednisolone was administered within 8 hours, the pooled results at 6 and 12 months indicate a modest improvement in mean motor scores in the group compared to the control group. There is no statistical difference between treatment groups and the risk of complications. And so we suggest a 24-hour infusion of high dose be offered to adult patients within 8 hours as a treatment option. And again, not a 48-hour one. So that's kind of where some of us stand. I think I kind of fall into this category that it could be used. It's not sacrilege to use it. It just that realize that if you're going to use it, you should probably use it, you know, based upon the dosings that have been tested. I'll give dexamethasone sometimes because the dose of dexamethasone is way, way, way smaller, and we use dexamethasone all the time without complications, but it's probably not doing anything, quite frankly. Um, but I usually will give it if I'm heading to the OR to operate on somebody because I'm also giving it as a neuroprotective drug in case I cause an additional injury in the OR. Um, but some people are vehemently against steroids, some are still vehemently for them. But I think until there's additional trials, then it's probably not going to be ever really put to bed. Um, so lastly, because I know it's already after 5 o'clock, I just want to talk a little bit about what we have started doing here at Elmhurst. We've done this on 1 patient so far, but basically is using CSF diversion, using a lumbar drain really to both measure spinal cord perfusion and to use CSF diversion to basically maintain spinal cord perfusion pressure in a certain area. So it's kind of the corollary to TBI in that oftentimes when we have TBI, when we have a patient with TBI, we'll do a decompressive hemicraniectomy, and then we'll place an ICP monitor, and from that we can calculate somebody's cerebral perfusion pressure, right? So we want to keep their cerebral perfusion pressure in a certain range to make sure that they're getting adequate oxygenation and blood flow to the brain, but it's not causing like hyperemia or ICP issues, and that's calculated from the MAP minus the mean arterial pressure minus the intracranial pressure. So if you place a lumbar drain in somebody that has a spinal cord injury, you can do something similar. You can calculate out the spinal cord perfusion pressure, which is going to be equal to the mean arterial pressure minus the CSF pressure. And it makes kind of intuitive sense that these numbers, or where we want to keep these numbers, is probably similar, right? They're both central nervous system tissue. The only thing your body does really normally is changes the map and changes the arterial diameter, by constricting or dilating it. But, probably given the fact that they're both central nervous system tissues, it's probably in reality the pressure that your body wants for your brain and your spinal cord is probably relatively similar. And sure enough, what they have found is that spinal cord perfusion pressure greater than 50 may be a predictor of improved neurological recovery. You might say, well, TBI we use 60, but actually in TBI the reason why the guidelines are 60 is because we know that 50 in the brain is the ischemic threshold. So at least the data seems to indicate that it's basically the same threshold for both the brain and the spine. That a perfusion pressure of more than 50 is where you want to keep it. And so I think 2 years ago at our very first New York Neurotrauma Consortium Symposium, we had Dr. Okonkwo from Pittsburgh, from UPMC, came and gave a talk about doing this. And so, either at the beginning of the case or the way I think, the way we did it, which was my preference, was to do it at the end of the case. You could also do it, when they got back to the ICU, but it seems to make sense to do it in the OR at the end of the case is to place a lumbar drain and then, use their map and monitor similarly with a transducer, either their intrathecal pressure or their CSF pressure, and then calculate out their spinal cord perfusion pressure. And what they showed is they did this in 92 patients. As multi-center, prospective, and they basically showed, um, uh, you know, uh, if you looked at somebody's map, the number of episodes where they had a low map, say, there wasn't really a much statistical difference in, whether they improved or not, which kind of goes against what we know about map augmentation. But then if you looked specifically at spinal cord perfusion pressure, those patients that had less episodes where the spinal cord perfusion pressure was low, less than 50, those patients had a much better chance of improving than those that did not. So that in the ones that improved, they had less episodes essentially. The ones that did not improve had more episodes of lower spinal cord perfusion pressure. So the risk of neurological improvement is about 4 to 6 times higher when the spinal cord perfusion pressure is between 60 and 65 millimeters of mercury. So again, similar to kind of what we target for the brain. And so, again, this was blunt spinal cord injury. It's now the standard practice at Pittsburgh, UCSF, and in Vancouver, a glowing list of other places. And so we're probably, we're going to put it as an option in our protocol and see how it goes with a few more patients. But assuming we don't have no issues with it, we'll probably start to incorporate it as a standard practice here as well. But yeah, and there's a separate kind of like algorithm, but basically what you do is you monitor your spinal cord perfusion pressure. If it's low and your map is low, you increase the map. If the map is where you want it to be, over 85, and spinal cord perfusion pressure is still low, but your CSF pressure is high, then you open up the lumbar drain and drain some CSF. Uh, you know, you don't want to overdrain, so you only drain 10 to 15 cc's, and then clamp it, and that should have corrected yours. Your spinal cord perfusion pressure will then be normal again. I won't get into this, but cerebrovascular injury, we've talked about many times. I think we're all kind of up to date on that, but we can talk about a lot of that. Lastly, just to finish up, in terms of long-term follow-up, patients can have neurological improvements for 2 or more years after a spinal cord injury. Fusion takes about a year to 2. Deformity, pain can sometimes take a long time to improve. And it's important to realize that most spinal cord injury patients do improve. Asia A complete ones, again, it's low. It's by far, that's why, oftentimes we'll wait even a couple days after, surgery, after the decompress to see if they actually were complete or are a complete injury, because this does have a much worse prognosis, and so you don't want to mistakenly categorize somebody as an Asia A if they're not really. 11% improved, but 3%, almost 1 in 20, not quite, improved to a grade D, which is pretty good, or grade E. Asia B, which is a motor complete, 44% of them improve, almost over a quarter of them get to the point where they're more than 50% anti-gravity. A small percentage worsen with time. Asia C, the vast majority of them improve, and then Asia D, almost all of them improve. So this is a good article too. It's about who's actually going to walk, and then obviously this is again doing the first examination at 72 hours because it's less likely to be confounded by other things, medications, other injuries. But their 1 year follow-up Asia grade, for somebody that was an Asia A, 84% of them were still an Asia A, but 16% of them had actually improved at least 1 grade, 3% all the way up to Asia D. And basically what it shows is that, your chance of walking, if you have an Asia A cervical injury, pretty low, as well as Asia A thoracic and lumbar. But for everything else, Asia B cervical is still relatively low, but everything else is actually pretty high in terms of the chances that you're going to walk. So Asia B thoracolumbar, pretty high still, in the 60s to 80 range. We talked about that. So this was a trial implanting a spinal cord, a scaffold into the spinal cord. We were one of the sites. We unfortunately didn't get to enroll anybody because there was only enrolled like 23 patients amongst all these sites because it was a phase 2 trial. But we are going to be, we're having our site visit for this one in about 2 weeks. And this is going to be for acute cervical spinal cord injury. Um, and it's not just Asia A like the other one was. The other one was Asia A thoracic, which was pretty rare. This is a wider range of folks, and it'll be infusing an anti-inflammatory medication in them in the acute and chronic setting to see if it improves their outcomes. Yeah. So that guy we talked about initially, he improved all the way by 7 months post-injury to an Asia D. Is ambulating with a rolling walker. He regained his bowel and bladder function. He had some neuropathic pain, but otherwise did very well. All right, sorry for going over. But yeah, anybody have any questions?
Dr. Hickman, I actually do
Yeah,
have a quick question. I know
sure.
probably there's like non-existent data on pediatric patients, but are we pretty much like extrapolating essentially the same protocols?
Yeah, I mean, since I'm not as up to date on the pediatric side because we don't typically, most spinal cord. I mean, it's much rarer to have um, a bad spinal cord injury in a pediatric patient. Uh, and two, we don't see them here as often because it's as opposed to like a big epidural where they're gonna die. If they came in with, if it was like a 7-year-old that came in with like a burst fracture, we're still probably gonna transfer them. So I'm not as up to date. What I would say though is that, um, you know, in the immature spine, so the immature spine, it makes physiological sense that you would treat everybody that is probably, we treat anybody that's 15 or higher as an adult because that's the age cutoff for trauma between pediatrics and adults. So 15 and older is an adult. That being said, the spine is often reached its skeletal maturity by about age 12 or so. So you you know you can make the argument in that 12 to 15 range if it looks like, based upon the CT scan, if it looks like, the facets have matured and they're not as shallow and whatnot, you could probably treat it similarly. Most of the patient's growth and things like that is going to be from their long bones, right? At that point, not from their spine. Um,
Uh,
yeah. So, but if you're talking like a young kid, like it's like 6 or 7, um, you know, again, that'd be something that we could ask Dr. Morgenstern, but I'm not, or Dr. Margettis, because I'm not as up to date on that. But I think a lot of it we probably still are extrapolating. We have specific. I'm not aware of any specific spine trauma guidelines for pediatrics. Not similarly like pediatric TBI guidelines. We have updated, very recent guidelines for, but I'm not aware of any pediatric ones. I mean, it's only been 10 years since we've had the adult ones from on the double ANS CNS side. Um, that being said, the pediatric spine, um, what you're more likely to see, right, is a spinal cord injury without a fracture. So the old saying of, the old terminology of skiwara, I don't really like that term anymore because it's kind of, it was a term that came about prior to MRI, and even really prior to CT scan, although it was still carried over into CT scan. So spinal cord injury without radiographic abnormality. And the reason why that terminology came about is because the pediatric spine has a lot of um, uh, biomechanical differences compared to the adult spine based upon its immaturity. So the facets are not as, particularly in the thoracolumbar spine, but they're not as like vertically oriented. They're like flatter, and so they're more prone, more prone to sublux. um, um, with those facets. Um, Again, the ligaments themselves are more lax, and so you can have like a transient subluxation or translation, and then it bounce back, and it will look for all intents and purposes on a CT scan or an X-ray as if nothing had happened, but the patient had, you know, a few milliseconds or a second where the spine had completely subluxed, and caused a spinal cord injury and then it's back. Actually, I think probably I don't know if it's been updated since, but in Principles of Pediatric Neurosurgery, I actually wrote the 2 chapters on spine trauma. So, yeah, but I don't. As far as even in writing those, there was no guidelines. At least at that point, that was about 10 years ago when I did that. But there were no guidelines at that point on pediatric spine trauma. But there's a lot more. You have to be a lot more. Where there are guidelines are like clearing the C spine. You have to be a lot more careful in clearing the C spine in a pediatric patient. And so, our protocols and the standard of care now, which is to use a CT scan to clear the C spine in an obtunded patient or any patient really. And if that really only applies to adults, right? So if you can't apply that to pediatric patients because of the fact they are much more likely to have an injury or a ligamentous injury, and you can't see it because of the fact that their ligaments are more lax, their facets are more shallow. There's some other differences too, but yeah. So that using a CT scan and saying that somebody's unlikely to have a clinically significant ligamentous injury. If their CT scan, high quality CT scans negative in all 3 planes, that only applies to adults.
Got it. Okay, thank you.
Yeah. And I didn't include that in here, but the old school way of clearing somebody's C-spine was, um, if they had any tenderness or certain mechanisms, we still use, um, Canadian C-spine rule, things like that, whether to get imaging or not. But then, say their imaging was negative but they still had pain. The old day was like, okay, then you would get flexion extension films to make sure that they had no subluxation. But then a lot of those patients had pain, and so they couldn't get flexion extension films, and so you would keep them in the collar until their pain went away. Or if they came in obtunded or intubated, then your decision was to keep them in a collar and get an MRI. But you would have to get the MRI in like the first 48 hours, basically, maybe 72 hours, because after that point, the edema in the ligament, any ligamentous injury is going to subside, and so you could have a false negative. Or we would do like flexion extension in obtunded patients with you like holding the head and like doing it under fluoro. So that's the way we did it when I first started. But basically, uh, Dr. Okonkwo again from UPMC, he and his group showed that basically in obtunded patients that they looked at CT scans, and the quality of CT scans has gotten so good that if you looked at a CT scan and there was no subluxation, there was no translation, no subluxation, the facets were all well aligned, there's no fracture, significant structural fracture, no interspinous widening, the ADI is normal, all that stuff. If it's like stone cold normal, then the chances of that patient would have a clinically significant injury on MRI that you missed is about 1 in 10,000. So it's very low. And then subsequent other studies confirm that same thing within meta-analyses and systemic reviews and things like that. They all confirm the same thing. So probably almost like 8 years ago now, maybe even longer, um, maybe almost 10 years ago now, New York State Trauma Advisory Council basically recommended that we stop using MRIs to routinely clear the C spine, basically, and both in obtunded patients and awake patients that are adults, that you can use a CT scan to do it, you know. And then there are some other studies like, so what do you do if like the patient has a isolated C spine TP fracture? Is that clinically significant? Well, people have looked at that and they found that if that's all you have, then you're highly unlikely to have a ligamentous injury associated with it. So that patient, I would just get a CTA to make sure their vessels are okay, but wouldn't keep them in a collar or they could be cleared. So where you have to be a little bit careful is elderly patients that have, bad degenerative disease, the argument there is that, you can still clear their C-spine because they're not going to be unstable. The only reason to keep them in the hard collar maybe is so that the kind of, you know, warn them or to give them some additional support in case they were to fall. You know what I mean? But yeah, there's really no, those patients, if they have, um, bad spondylosis and they have even if they have a central cord injury, they're not overtly unstable. So really keeping them in seat collar is probably not of any benefit. Any other questions? No, good. Everybody clear on the Asia grading scale? Somewhat.
Yeah.
Yeah, I mean the important thing is like the rectal exam is that one we as a team, given kind of its importance, is we shouldn't really rely upon what the trauma team tells us or anything like that. We should make sure that we're doing somebody from our team is doing it, and the things you want to check are, again, the sensation over the ischial tuberosities. That's going to be S3. Sensation on either side where the rectal mucosa changes to the skin, and then when you do the rectal exam, and you obviously want to tell the patient what you're going to do, you don't want it to be a surprise. You want to be like, I'm going to do a brief rectal exam. I'm going to insert my finger about an inch. When I do that, I'm going to push on the inside wall. I want you to tell me if you feel it, and then I'm going to ask you to squeeze around my finger and let go, and then get their consent, obviously, to do it. And if it's, you know, if need be, have a chaperone. It's always good to have a chaperone, regardless. And then what you're really testing for is that deep anal pressure, and then the voluntary anal sphincter contraction. All right. Well, thanks, guys. We've been recording these, so I will make sure they're in the staff folder so that you guys can access them later.
Thank you.
Thank you.
Thank
Okay.
you.
Thank you.
Thank you.